Welcome everyone to today's webinar, Team-Based Care Strategies to Improve Patient Outcome. This session is brought to you by No Diabetes by Heart, a joint initiative by the American Heart Association and the American Diabetes Association. My name is Dr. Odika Busui, and I will be moderating today's sessions. To share a little bit about myself, I am the Larry D. Soderquist Professor of Diabetes, Professor of Metabolism, Endocrinology, and Diabetes at the University of Michigan, and Vice Chair of Clinical Research in the Diabetes Institute. I'm also the President-elect for Medicine and Science of the American Diabetes Association. Today, we will discuss how to identify opportunities to improve communication among the healthcare delivery team, to develop treatment plan based on ADA and AHA guidelines for improving health outcomes in patients with type 2 diabetes, and recognize barrier to diabetes healthcare maintenance. We are joined today by Dr. Tracy Tavera, Professor of Pharmacy at the University of Rhode Island and Adjunct Professor of Medicine at Brown University, with a clinical and research appointment with the Department of Veteran Affairs Medical Center, and by Dr. Khurrum Nasir, Professor of Cardiology at Weill Cornell Medical College and a preventive cardiologist at Houston Methodist, the Baker Cardiology Associate, and also Associate Editor for Circulation, Quality of Care, and Outcomes Journal. Before we begin, we would like to recognize the No Diabetes by Heart founding sponsor, the Novo Nordisk, as well with the national sponsor, Bayer. Thank you for your support. We invite you to visit the No Diabetes by Heart website, nodiabetesbyheart.org, for downloadable patient materials that will support you in your practice, for guideline information, case studies, and the library of our previous webinars and podcasts. Please stay tuned as we continue to roll out more webinars and podcasts for all healthcare professionals. We will be hosting a Q&A session at the end of today's presentation. If you have questions as we move through these presentations, please type them in the Q&A box, which is located in your control panel. We will try to answer as many questions as we can at the end of the session, and we will also try to answer those that we are not able to cover today in follow-up messages. Listed on this slide are our faculty disclosures. And now we are really excited to have Dr. Tavera and Dr. Nasir present today. And with that said, I will turn it over to Dr. Tavera. Dr. Tavera.
Thank you, Dr. Busui. First, I'd like to begin by thanking the American Diabetes Association and the American Heart Association and the No Diabetes by Heart Organization Committee for inviting me today to speak on a topic that I'm very passionate about, because in addition to my academic and research appointments, I have provided care and have coordinated a team-based multidisciplinary cardiovascular risk reduction clinic for patients living with diabetes and heart failure for the past 20 years at my clinical practice site. I also serve as the Director of Interprofessional Education for the University of Rhode Island College of Pharmacy. So today, my goal is to start with a brief case that characterizes the complexity of care that the typical patient living with diabetes of a patient that we see typically in our daily practices. Then I'd like to briefly discuss the evidence to support team-based strategies for our highly complex patients and identify the key elements found in effective team-based care models. I also want to acknowledge the potential barriers that providers face in our current healthcare system in providing optimal team-based care for patients, and then circle back to our case. So our first case we have is TH, who is a 68-year-old male who presents to his primary care visit with complaints of slight nausea and muscle weakness. His past medical history is significant for hypertension, type 2 diabetes mellitus, stage 3A, A2, chronic kidney disease. He's had a prior myocardial infarction and has a diagnosis of peripheral vascular disease. His 24-hour dietary recall reveals that he usually only eats 2 meals per day with foods high in potassium content, which include banana, peanut butter, and marinara sauce. His physical exam is generally unremarkable, except for a BMI of 46.5, which would put him into a category of class 3 obesity or severe obesity. His blood pressure is above recommended targets at a level of 148/80. He's currently maintained on chlorthalidone, lisinopril, and metformin, as well as ibuprofen. His most recent labs are unremarkable, except for an A1C of 8.4%, a potassium of 5.3 milligrams per deciliter, an eGFR of 42 mils per minute, and a microalbumin to creatinine ratio of 72. So the question is, where do we even begin with such a complex patient? And so I'm going to put a poll out to the audience to see what issues or health-related problems would you prioritize for this patient. So if we could start the poll, our first option is, would we prioritize glycemia, obesity, renal protection, tobacco use, or all of the above? All right, good. So the majority of you are saying all of the above. And that's kind of what I anticipated. And I think in an ideal world, it would be great if a patient care visit played out like a sitcom or a Hallmark movie where the problem is presented and there's some conflict and all the issues are resolved within 30 minutes. And then everyone lives happily ever after. But in the real world, unfortunately, it doesn't work that way. And in our current healthcare system design, we don't usually even get 30 minutes to address all of the healthcare issues that our patients present with. You might also be wondering that on this slide, I've included a picture of a hammer and a nail. And my reasoning is that because of the question that I posed regarding priorities, it reminds me of an old adage. If the only tool that you have is a hammer, you tend to see every problem as a nail. And this is to remind us that as we are trained as health professionals, our training and our perspective plays a role in the way that sometimes we prioritize the care for our patients. As a pharmacist, when I see these patients' profiles and his current potassium level, I'm quick to think that maybe the hyperkalemia could be attributed to his ACE inhibitor. And I think that maybe we could use another drug like an SGLT2 inhibitor or potassium binder to lower his potassium level so that he can be maintained on an ACE inhibitor for the renal protective effects. Now, for some of the registered dietitians in the audience, they will likely also recognize that a potassium level of 5.3 is problematic, but may feel that his dietary intake is what's largely contributing to this current level. And these health professionals would have the necessary knowledge and skill to educate these patients regarding medical nutrition therapy. So what I'm trying to underscore here is that perspective, skill set, and approach of healthcare professionals are very diverse, but I think these differences are positive in that they're complementary when we unite. It helps us to provide high quality, comprehensive team-based care for our patients. Regardless of our own perspective and training, the most recent ADA standards of care and the recently published ADA EASD consensus statement underscores the importance of a holistic approach to individualized care that asks us as health professionals to go beyond just considering the absolute risk and benefit of alternative therapeutic options. But it encourages each member of the healthcare team to use shared decision-making to incorporate patients' preferences and identify individual barriers to care. And I believe that the reason for this adaptation of this care model and figure is because there truly isn't a one-size-fits-all care approach for people living with type 2 diabetes. As we know, it's a very heterogeneous disease with variable age of onset, varying degrees of obesity and insulin resistance, and a different propensity for developing diabetes-related complications. And furthermore, this care model underscores that these patients are presenting to us with multimorbidity or competing demands. Patients such as those with diabetes and heart failure may have a symptom burden that limits their ability to perform optimal self-management activities. And furthermore, the cost of multiple disease states may confer additive burden and may limit adherence to optimal guideline-directed medical therapies. And finally, this care model approach stresses the importance of evaluating social determinants of health that independently contribute to medical and psychosocial outcomes for persons living with diabetes. And so this is obviously an optimal strategy of care for our patients, but this is a lot to unpack, especially in the traditional care setting. Research has shown us that the duration of a traditional primary care visit is about 15.7 minutes. And in that time, the primary care provider is expected to assess the patient's labs and glucose logs. And even with the best technology, trying to decipher and at times troubleshoot these devices can be very time consuming. The provider is also expected to reconcile the patient's medications, confirm their level of adherence, and they're also expected to provide health promotion and preventative education, not only specifically to diabetes, but for overall health. And then finally, document all this relevant data in the electronic medical record. Once these required activities are complete, it leaves very little time to provide specific diabetes self-management education and support, and definitely even less time to provide important medical nutrition counseling and to assess and address important diabetes-related social determinants of health, such as socioeconomic status, neighborhood and physical environment, food security, access to healthcare, and social support. And I think about how difficult it is and time-consuming in my own practice to gather this very important and sensitive information from patients in a non-judgmental way so that you can provide meaningful interventions to overcome important and common barriers to care. Furthermore, we know that disparities in diabetes-related outcomes exist for racial and ethnic minorities. And the underlying mechanisms driving these disparities are not fully understood, but it seems that the traditional care setting may further intensify the differences in outcomes because providers had limited time to gather information about culturally based dietary habits, about patients' perception of health and illness, and further sensitive information. Furthermore, research has shown that discordance of race between providers and patients confers a lower level of communication quality and participatory decision-making for Black patients as compared to whites. So, if the current design of the current healthcare system is not optimal for patients' outcomes, then the questions I think my students would ask me is, then why does it continue to function in this way? And my belief is that it's because in the United States, we are largely a fee-for-service reimbursement that is driven by volume and not necessarily by quality of care. And so, since no financial incentive is provided for care coordination or health outcomes, then fragmentation of care is likely to occur. And in the instance where a patient may have, say, a primary care doctor, endocrinologist, and cardiologist, and may have concomitant diabetes and heart failure, and is maintained on insulin therapy, I think we would all agree that the patient would benefit from an SGLT2 inhibitor. But who will get it started? The cardiologist? Well, who will be responsible for titration of insulin therapy? And how will these changes be communicated? Through the primary care provider, the patient themselves, or directly amongst the providers? And I think later we'll have some time to pose these questions to our expertise, to our endocrinologist and cardiologist, Dr. Nasir, to see how they approach best practices. Disparities in care are likely going to be further exacerbated by limited access to care. In the next 10 to 15 years, the shortage of primary care providers is projected to be between 40 and 124,000 providers nationwide. And since most payers require referral from a primary care provider to specialty care, this may further delay important care for prevention of diabetes-related complications. It's also projected that the percentage of adults with diabetes will increase to almost 14% in 2030 in the United States and up to 18% by the year 2060, which will further exacerbate the strain on the current healthcare system. The American Diabetes Association provides the recommendation to align approaches to diabetes management with the tenets outlined by Wagner's chronic care model. This model emphasizes a person-centered, team-based approach of integrated care to address diabetes and related comorbidities and encourages ongoing collaborative communication between all team members. And this recommendation received an A-level reading, meaning that it is supported by the highest level of quality randomized controlled clinical trials. So what is meant by team-based healthcare? Well, as initially defined by Mitchell and colleagues, team-based care is the provision of healthcare to individuals, families, and communities by at least two health providers who work collaboratively with patients and their caregivers to accomplish shared goals within and across to achieve coordinated high-quality care. The data to support team-based care was largely derived from 35 studies comparing usual care to a team-based care intervention, many of which included components of diabetes self-management education and support delivered in an evidence-based strategy in line with the constructs from the chronic care model. These interventions demonstrated statistical and clinically significant improvements in glucose control, blood pressure, lipids, diabetes-related quality of life, and in general, physical and mental health, and showed important reductions in hospitalizations and in emergency department utilization. When we dive deeper into the literature and the evidence to identify the key components of team composition and how the team members would operate, it was found that similar improvements in patient outcomes were reported when teams added either one or two members, usually a nurse or a clinical pharmacy specialist, to the patient primary care provider relationship. There were also additive gains in blood pressure control when a person with prescriptive authority, such as a nurse practitioner or a clinical pharmacist practitioner, were added to the team as compared to those that only allowed medication changes by the primary care provider themselves. Programs that also allowed team members to access the medical records showed greater improvement in blood glucose control. And interventions that involve explicit communication, such as direct verbal communication among team members or team-based patient case discussion in groups, showed more favorable blood pressure outcomes as compared to studies with implicit communication, where written recommendations were simply added to the patient's electronic medical record. Programs that delivered combined in-person and remote interventions were superior to interventions that either delivered their intervention solely in person or solely remotely. So, despite the robustness and the strength of this data to support team-based care in patients with diabetes, there's still a paucity of data on how these strategies will work in patients with type 1 diabetes. We also don't know how well these interventions will work in teens or in younger patients who are still fully employed full-time and may not have time for these intensive interventions or multiple care visits. We're also not certain how to access multiple care providers or how access to multiple care providers will be covered in patients who are uninsured. And we also don't know exactly how we would implement these interventions in rural settings where the availability of providers with diabetes expertise may be limited. One proposed strategy to deliver high-quality, multidisciplinary team-based care in an efficient manner is via shared medical appointments. Shared medical appointments are group visits which several patients meet with either one provider or multiple providers at the same exact time. Shared medical appointments are proposed to be an efficient team-based strategy because this model would add pharmacotherapeutic management and behavior modification to a previously established model of diabetes self-management education. However, previously it was unknown whether it would be feasible or effective or what the added costs would be for the healthcare system. So in 2020, my colleagues and I conducted a 3-site randomized control trial of 249 subjects to compare our shared medical appointment model, which consisted of 2-hour sessions that met weekly for 4 weeks, followed by 2 90-minute monthly booster sessions, which were held at month 2 and month 5. There were approximately 4 to 6 participants per class, and each class consisted of 2 components. The first half being education delivered by either an RN, an RD, a PharmD, or a Master in Social Work. And the second component consisted of behavioral and pharmacologic interventions provided by either a pharmacist practitioner or a nurse practitioner. What is depicted here is the change in hemoglobin A1C, systolic blood pressure, and lipid control at 13 months of follow-up. In these graphs, the blue lines represent the SMA intervention and the red lines represent the change in the control arm. And if you recall, the intervention was front-loaded in the first month, and the last visit for the intervention group was at month 6. So it isn't surprising that we observed the greatest change during this time period. And like most behavioral interventions, when we withdraw the intervention, we see regression back to the mean. So overall, at 13 months, outcomes were very similar between the groups and suggested that perhaps booster sessions were needed to either prolong or sustain the effect. However, what we did find was that although there was an initial increase in cost because of the intervention, that as compared to the year prior, those who were randomized to the intervention in the SI arm had a 13% reduction in healthcare-related costs in the following year, whereas the control had a 6% increase in cost in the follow-up year. And these are health-related costs. When we look at patients' perceptions and their own physical function, we found that those who were randomized to the SMA intervention had an improvement in physical function scores. But again, the effect was attenuated and not necessarily durable once the intervention was withdrawn. So the data from several small studies involving SMA was very compelling and promising. The Department of Veteran Affairs provided funding to David Edelman and colleagues out of Duke to conduct a systematic review and meta-analysis to determine whether shared medical appointments should be offered as a standard of care throughout VA nationwide. Much of the group's work, our group's work, made up this data, and they concluded that overall, shared medical appointments improved glycemic control. However, there was a significant level of heterogeneity given the differences in patient population, frequency of visits, and duration of follow-up. The meta-analysis also demonstrated that shared medical appointments improved blood pressure control over usual care. So the data to support implementation of team-based SMAs seem compelling, but how do we go about implementing this strategy for patients who live in rural settings that have limited access to diabetes healthcare specialists? My colleagues and I wanted to determine whether this was feasible, safe, and efficacious to deliver shared medical appointments via video conferencing. We originally designed our trial to have our multidisciplinary team of providers who are located in Providence, Rhode Island, to deliver virtual-based shared medical appointments to groups of 4 to 6 individual participants who are living in Guam. And personally, I pride myself with knowing the carb, protein, and fat content of the top 100 most consumed foods eaten in New England. But I realized that after one session of the study, that it was fatally flawed, and that I had literally no cultural competency when it came to working with Asian Pacific Island dietary patterns. We quickly went back to the drawing board and found additional team members, which included a nurse and a pharmacist from Hawaii who had an in-depth understanding of dietary patterns, cultural values, and norms of Asian Pacific Islanders, who agreed to deliver the intervention with me. What we compared was the change in A1C and blood pressure of our virtual SMA intervention to time-matched controls after 5 months of follow-up. Those who were in the virtual shared medical appointment on the right had improvements in A1C, whereas the time-matched controls group's A1C had worsened over the follow-up time. We also found that there was a trend towards better improvement in blood pressure control, which was not significant. But again, this study was not designed to test, it was designed to test feasibility and safety and not necessarily effectiveness. As part of our safety outcome, we tracked emergency room visits and hospitalization, because the concern is that if you're talking to a patient locally, either virtually or over the phone, and you're not able to fully assess the patient's situation or the complaint that they're presenting with, you would ask that patient to come into your office for further assessment. However, when you're conducting virtual visits that are halfway around the world in a completely different time zone, you can't fully evaluate the situation. And the concern was whether or not we would generate unnecessary referrals to the emergency room or even generate unnecessary admissions. What we were relieved to find was that although the numbers are small, the virtual SMA had significantly less emergency department visits. So I'm hoping by this point, I've made somewhat of a convincing case or an argument to support the value and the feasibility of team-based care. And if we circle back to our patients, I'd ask you again and put out a poll, what other interprofessional team-based members would TH benefit from? A nutritionist, a pharmacist, a nephrologist, or all of the above? Great. Okay, so very comprehensive in care. The majority of you answered all of the above. It's kind of a trick question though on my part. So my students know I'm notorious for those. So let's go back and revisit our patient case. By guideline recommendation, TH wouldn't necessarily meet the criteria for immediate referral to a nephrologist because its eGFR remains greater than 30 and his microalbumin to creatinine ratio is less than 300. However, as the audience, you would need to know if he had previous values above or below this threshold and how precipitously his renal function changed, because that would necessitate a sooner rather than later referral. We see that his diet is high in potassium and likely sodium and had an adequate amount of protein for his body weight. He could definitely benefit from dietary counseling for weight loss and may benefit from pharmacotherapy to assist with weight loss given the severity. He would also benefit from medication optimization to achieve target blood pressure goals. Looking at his current medication profile, I'd ask the audience whether or not he would need an adjustment to his current metformin therapy. We would need to determine what the indication is for his ibuprofen and determine if there's a safer option. He would probably also benefit from renal protective therapy. So again, I'm going to put out another poll to the audience and ask you, what modifications would you make to TH anti-hyperglycemic pharmacotherapy regimen? We'll open the poll. So A is decrease metformin to 1,000 milligrams, add dapagliflozin, add glyburide, both A and B, or all of the above. And I can tell this is a very sharp audience, so I know they're going to get this one right for sure. Okay, excellent. And the majority got this one correct. The answer is both A and B, correct. We would have to dose reduce metformin to a max of 1,000 milligrams daily and add an SGLT2 inhibitor for renal protection. At this time, I would advise against the addition of glyburide, given its propensity to cause weight gain and long duration of action, contributing to an increased risk of hypoglycemia for this particular patient. And these recommendations are largely based on two randomized prospective trials, the Credence and the DAPA-CKD. In the Credence trial, participants were randomized to either canagliflozin or placebo and had to have a diagnosis of type 2 diabetes, and along with a microalbumin creatinine ratio greater than 300 and an eGFR greater than 30. The participants who were randomized to canagliflozin had an overall 30% decrease in the composite outcome of requiring chronic dialysis, kidney transplantation, or a sustained eGFR less than 15 mils per minute, a doubling of serum baseline creatinine, renal death, or cardiovascular death. There was also a significant reduction of 32% of progressing to end-stage renal disease. Likewise, in the DAPA-CKD trial, participants who were randomized to dapagliflozin versus placebo. Interestingly, in the DAPA-CKD trial, participants did not necessarily have to have a diagnosis of diabetes, but had to have an eGFR greater than 25 or a microalbumin to creatinine ratio greater than 200. And similar to the findings of the Credence trial, there was an overall 39% relative risk reduction in the composite outcome. And again, a significant reduction in the progression to end-stage renal disease. Therefore, it's not surprising that the current ADA standards of care and the current ADA EASD consensus statement makes the recommendation that regardless of background therapy with metformin, that patients with a diagnosis of CKD or an eGFR less than 60 or a microalbumin creatinine greater than 30 should be preferably started on an SGLT2 inhibitor with evidence of reducing CKD progression, and it should be continued until dialysis or transplant. So in conclusion, Caring for our patients with type 2 diabetes is complex, and it requires a team and sometimes a village. And I hope that some of the evidence that I've shared with you today have convinced you that team-based care is effective and feasible. But yes, barriers remain and more information is needed as to how to best implement these strategies in our current care delivery. And with that, I'll turn it back to Dr. Basui.
Well, thank you so much, Tracy, for this tour de force, indeed. And I would like to thank you, all of you who have joined us and submitted their questions. I would like to remind you, if you haven't done that already, please start submitting your question for today's panelist. And while you are typing, I would really like to give Dr. Nasir the opportunity to provide us with his perspective and some of the information that Dr. Tavera has presented, as well as on this team-based approach to the care of these very complex patients with diabetes. In the meantime, I will be also monitoring the Q&A. Dr. Nasir.
Well, thank you so much. It's such an honor to be here today, and I'll try to be brief. So for most of you who may not know me, I'm a preventive cardiologist, and it gives me immense pleasure to note that over the last 4 decades, we have witnessed significant reductions in mortality from heart disease, of course, related to greater access, procedures, processes of care, and also better medication, mostly in the realm of controlling lipids, blood pressure, and reducing thrombotic complications historically. Now, as far as diabetes is concerned, perhaps the greatest nemesis for us in cardiology, while in the past, the approach that has mainly been glucose-centric from a cardiology perspective, where we didn't see much benefit derived as far as the macrovascular morbidity and mortality. The role of the cardiovascular specialist was really limited for diabetic patients in proven interventions for cardiovascular disease, such as lipid lowering, blood pressure lowering, optimizing antiplatelets. Now, however, kudos to the innovations over the last decade that have completely turned the tide, where now our emphasis have shifted not only from HbA1c lowering, but now comorbidities and risk. And specifically now, in 2022, we have well-proven interventions to lower cardiovascular morbidity, mortality with these 2 new groups of agents. As a result, I think the current cardiovascular specialist should be well-positioned, of course, since we didn't have, I would say, the practice or the culture to address these 3 areas in the management of patients with type 2 diabetes. One, in screening for type 2 diabetes in their patients with or without high risk for CVD. Of course, aggressively treating cardiovascular disease, but also taking on the onus for incorporating the data that we have for the newer anti-hyperglycemic agents for routine practice. Now, in 2022, it's clear if you look at all the data, national cardiology practices, even in my own institution, and of course, well alluded, the major challenge we all face together is the phenomena of therapeutic inertia that continue to limit us in rapidly providing the evidence-based treatment for the right patient at the right time. In fact, it's a major issue recognized not only by ADA, by HA for the overall diabetes management, though we feel a bigger scope for high-risk CVD patients. So in essence, we are unable to maximally serve the best interest for our patients, the core rationale for our existence. I see in a cardiology clinic practice, especially all across the US, most healthcare systems are struggling and looking outward for solution, whereas if, in all honesty, if we introspect, the answer lies inwards. And the answer lies inwards is creating those specialty pods, and especially preventive cardiology taking the lead into incorporating the cardiometabolic management in their pathways, not only for the patients who are coming within the cardiology division. For example, you've clearly pointed the challenges faced not only with primary care, where the issue is time, expertise, operational, structural, prior authorizations, follow-ups, and the same challenges lies within the entire cardiology divisions, where patients are seeing in heart failure and intervention in general cardiology. So how do we address that? At Houston Methodist, we have tried to organize that as having a central hub of preventive cardiology, a 5-day clinic, a team-based approach that has team members, nurse practitioners, MAs, pharmacists who are helping us out, but a team of fellows, residents, and everyone, where it is a protocol-based approach where diabetes management, cardiovascular risk management with these novel cardiometabolic therapeutics are part and parcel of what we do. It's a protocol-based approach. Almost everyone is screened, identified who needs up titration. In all honesty, almost every, I would say, majority of the patients we see, 80 to 90%, with established heart disease that comes to our clinic, either from primary care or some other cardiology, is neither on one or two of these cardiometabolic therapeutics like SGLT2 and a GLP-1. In our clinic, we definitely try to prioritize depending upon ACVD or heart failure risk. And since it's a preventive cardiology, mostly our ACVD risk and coming with some, I would say, BMIs of 30 plus minus. So definitely the tilt is more towards a GLP-1 receptor agonist. Of course, a key issue is time. And as a result, not only we introduce the concept, but then bring them back for a diabetes CVD risk management visit only. Where we go all over the options, help them understand what these medications are, what do they do, how are we going to up titrate, what are the key things that we need to look around. Of course, the challenges are, as you pointed out, what do you do if these patients are already on concomitant type, I would say type 2 diabetes therapies. Now, of course, given the modest expected HbA1c reduction with about 0.5 to 1% anti-hyperglycemic dose, which are possibly sulfonylureas, PPP, DPP4s, and insulin, we directly message, contact with our fellows and MAs with our endocrinologists, if they have an endocrinologist or a primary care for requirement of titrations. And so we feel that this is more of a collaborative plan that's happening with our clinical pharmacist as well as primary care. Of course, the general principles are the same. For example, if their HbA1c is, I would say, less than 7.5, or they had any prior hypoglycemic episodes, we tend to stop the sulfonylurea medication. And I think so we are taking the onus, and our primary cares and endocrinologists are responding pretty well. If their HbA1c is still 7.5 to 8, you can potentially decrease the medication by 50%. Of course, if it's 8.5, you continue. From an insulin level, of course, our experience is pretty much limited. So we do recommend decreasing the basal insulin by 20 to 30% if HbA1c is on our target. We make sure that we are coordinating with the primary care physician and an endocrinologist. And of course, we ensure a follow-up in 2 to 3 weeks virtually, because again, that's a tool that we have, the telehealth, that we are not truly, I would say, adopting. And in that interim period, we have a targeted plan with either our primary care or endocrinologist, and we co-decide who's going to take charge of that. In our clinic, we are right now, especially for the GLP-1s titrations, we are taking the charge with our nurse practitioner who brings them, do a televisit once a month, checking on the CKD, weight loss, and increasing the doses from going from 0.25 to 0.5 to 1 and follow up. So in essence, what I just want to finalize and say that this is an immense area where cardiology needs to take ownership. I don't think so this is something that the entire cardiologists need to do, but we need to create a hub where all the spokes can come in, and it could also become a central piece that coordinates with the primary care and I would say our endocrinologist.
Well, thank you very much, Dr. Nasir. And because we also want to leave some times for questions, I like to try to direct some of the conversation based on the feedback that we are receiving. So first of all, of course, this was a lot of information, and we just want to point out that all these slides and the entire recording will be available for you to be able to digest I see some comments that there was a lot in in these slides, and we are going a little bit fast, but please be assured that you will have an opportunity to actually look at all this information at your leisure. Second, obviously, I think that we all have to have in mind that given that we are facing such a huge pandemic or such a huge epidemic of people with diabetes, and we all understand very well that, in fact, every person with diabetes should receive an optimal care. I don't think it's feasible to say that either of the specialties can have an ownership here, because that's just not going to be possible. And the secret here to deliver this best care would be to work as a team, as Tracy has so nicely pointed out. And speaking about that, I'm hearing and I'm interacting with many physicians and with many patients actually who come to see us. And, let's see your perspective. Who owns these medications that have been shown to be so effective to prevent both cardiovascular and as well as kidney complication? I don't think that anybody owns them, but I would like to hear your perspective, because I think that that's a message that may explain what you said, Dr. Nasir, inertia. I don't think that anybody owns it. So, and if we work as a team, we will be much more effective to actually, conquer this inertia. But Tracy, what do you think about it?
So as a health service researcher, I look at this from two perspectives, right? One from the patient perspective and one from the health system's perspective. And you have to, from the patient perspective, look at what the comorbidities are and what the complications are and who their specialists that are involved as part of the team, for one, and prioritize their preferences and who they prefer to kind of lead the ship. Secondly, you have to, we have to recognize that all healthcare systems are not equally created, right? There's different amount of resources, and those who live or are housed within integrated healthcare systems with very robust forms of communication, I think that's an advantage, right? But that's not every healthcare system, and that's not accessible to all patients living with type 2 diabetes. So we have to kind of say, who are my patients and what resources do I have available to me if I'm not truly embedded within an integrated healthcare system? And what's the most efficient way to, integrate and coordinate care with these patients? Say with patients, we have a local example here where they're part of an integrated system, but they don't have access in their local communities. And we've partnered with community pharmacies to kind of deliver those frequent touches and feedback that information to the system. So there isn't, unfortunately, a one size fits all, but there is an answer, I think, for each individual community when we identify. And so as far as ownership, it's again, what expertise is available, and we have to bring it back to the patient of who have they established their relationships with and what's their preferences. But Dr. Nasir, I welcome your opinion.
You have highlighted all the challenges, and the challenges are our healthcare system, unfortunately, it's siloed, it's disintegrated, and everyone is wearing a single hat. And I'm thinking about the future, and I'm saying, why can't we have a diabetes clinic with a primary care who's a diabetes specialist? And all they do is see diabetic patients, and they get their training as a part of cardiovascular management, lipid management, blood pressure, antiplatelet. They have deeper understanding on the kidney issues and, of course, on the diabetes. So a one single point person who wears all the hats eventually, who's able to manage, who's able to coordinate with their colleagues for, I would say, more complex issues. And that's the thing that we need to aspire to, because as you pointed out, 17 minutes per visit. And you're talking about my COVID flu vaccine, my colonoscopies, my backache, my blood pressure. And yeah, your HbA1c is 6.7 and you're just on metformin and doing well. Who cares? I think so. That's really the challenge that we need to address, because all what we are trying to do, I feel, are band-aid approaches where, as you know, our resources and how we deliver care are the same as we did in the 70s, 80s, and 90s. Our diseases, our options, and our complexities have increased. And I think so it's time to take a step back and asking ourselves, is it fair to ask our primary cares to do all?
Yeah, I completely agree.
I
I
agree.
think that we also have additional tools that we didn't have, 10 or 15 years ago. And with this integrated electronic medical records and healthcare system, this team-based approach becomes more and more feasible. And let's not forget that besides the primary care physicians, endocrinologists, cardiologists, and nephrologists, we do have additional very important team members, which are diabetes education, clinical pharmacists, and social workers. Again, we cannot say loudly enough that the same quality of care has to be available to all people with diabetes. And unfortunately, those who are living in more socioeconomic deprived conditions or have less access to care are unfortunately also those who have the higher risk for complications. But let me get to additional questions here from the chat because we have received quite a few of them. And one is referring to the case, Tracy, and perhaps something that we may want to consider also in people like the one that you presented is that in fact in patients with diabetes, this long-term use of non-steroidal anti-inflammatory agents can in fact have a dramatic effect on their kidney, and stopping in fact that medication could improve their EGFR and therefore would not raise all these questions whether SGLT2 inhibitor should be even considered. And again, as you have very beautifully shown, both with Credence and DAPA-CKD, in fact, these agents are very effective even for EGFR levels in the 20s, hence the labeling change. So question for you is, in a team approach, who would you refer first? To a dietitian first, to the PCP first, to the diabetes educator, the clinical pharmacist? Who should see that patient first, and then how should the team continue?
So we, in our current program, we kind of make that same exact decision of they're probably going to be referred as a team-based approach, but it's individualized based on what the priority is for the patient. So what is the most imminent reason from a provider perspective of, what's the most dangerous or compelling? And then from a patient perspective, we put it out there. These are the menu of options that you have available. You can visit with a dietitian. That's obviously very important for you. Is that a priority that you want to tackle right now? And they may say yes or no. And that's something to always go back and revisit. Patients may come in truly motivated for, to improve their dietary patterns. However, they may not have the actual financial resources to purchase these foods. So sometimes our first stop is with a social worker to figure out what resources are available to network them to better food sources. So again, we usually tailor the approach and prioritize them based on the imminent need and the preference of the patient.
Thank you so much. And Dr. Nasir, there is a question for you. Are statins absolutely necessary for the prevention of a cardiac event?
It all depends. If they have an established cardiovascular disease. So again, in the past, we used to equate diabetes as cardiovascular disease equivalent. However, over the last many years, we know that's not true. There are different flavors. Of course, if you are an established somebody with a prior heart attack, stroke, or peripheral arterial disease, those are the highest risk patients. Highest dose statins, LDL less than 70, systolic blood pressure is less than 130, antiplatelet, those are the best practices. And depending upon whether higher CVD or heart failure risk, definitely a GLP-1 receptor or an SGLT2. Now, in individuals who do not have any of those, the risk is variable. Not everyone is the same. For that, I'm sure you must have heard about the coronary artery calcium testing, which is a non-contrast CT scan that helps us understand where you are. 1 in 3 patients will have no disease. 1 in 3 will have significant disease, and 1 will be in the middle. Statins, yes, if they have the disease. And we have also shown that individuals with the highest atherosclerotic burden will also benefit from the GLP-1 receptor agonist and icosapent ethyl. So in short, statins for everyone who have established disease. If they don't have, you can be flexible. But mind you, diabetes and CVD, the worst combination.
Thank you so much. So we have another question here about where does the CDCS fit in?
So for our where I practice in my state, in order to receive reimbursement, you have to be considered what's a certified outpatient diabetes outpatient educator. So oftentimes the clinical pharmacy specialist is also a CDE, the RN is also a CDE, and the registered dietitian. So there is so much overlap. We know how robust this is and how it's a lifelong process, because as life changes, experience changes, and we need to sometimes go back and revisit life skills. So we're constantly referring and tailoring and getting them in. So I feel that CDEs are integral to the lifetime continuum of diabetes care.
Thank you so much. Another questions, are there tools available to facilitate collaborative communication? And I would also like first to direct you to all the resources that No Diabetes by Heart has, collected and put together. And my colleagues here from the American Diabetes Association and American Heart are sending you through the chat all these resources as we speak. So there is lots of resources that can guide you in that arena. I can say from my perspective that at least in the University of Michigan health system, which is a single health system in where we have actually very direct collaborations with both our family medicine and general internal medicine providers, as well as with our cardiologists and nephrologists and surgeons, or you name it. We do create as part of quality improvement a variety of best practices, and we do have diabetes specific quality improvement committees that are putting together these best practices to enable, again, access to the best management for our patients, whether it's a screening test that has to be done at a certain time, whether there is a medication that may be actually needed based on the guidelines that are currently most current. And then again, when we look at guidelines, we need to keep in mind that besides the diabetes, the glucose lowering agents, statins, ACE and ARB continue to be under prescribed, unfortunately. So there are a lot of tools that, especially when we have integrated health system, we can now move this inertia. And Dr. Nasir, I think you said something very similar, that it's happening at Houston Methodist, right?
Yes. So, most of that, it's happening under the purview of the preventive cardiologist, where we are trying to expand these collaborations. And I'm just thinking out loud that in spite of all of these efforts, if you look at nationwide, although in diabetes with CVD, the statin use is 60%, the SGLT2 GLP is still hanging around 7 to 8%. And
True.
while
but
we
that's still coverage also, we have to keep that in mind too.
No, I totally agree. And then again, coverage is an issue, and I'm hoping that it's not responsible for the lack of 93% underutilization. So that's definitely one. Statin, we never had a coverage issue. We're still hanging out around the 60% issue. I really think that this is lack of the siloed approach. And, the more we are going to try to bring them together, it's great. But who is really in charge? We need a diabetes specialist who is coordinating that, who can get the televisits with the cardiologist, preventive cardiologist, with the renal as needed. And of course, if they have obesity with sleep apnea as an under-recognized, fatty liver is another thing that happens, low testosterone, it's a multi-organ disease. So in the end, we need a champion. And who's that champion? And that's where I struggle the most, because as a cardiologist, I can try as much as I can, but I need somebody who's going to be more of a champion. And it's just hard for our primary care. And we're trying with this whole notion and saying, can we create a primary care diabetes metabolic expert? And their whole role is seeing all of these diabetic patients. In our system, we have 175,000 diabetic patients. You may need about 10 to 15 of those primary care to coordinate. So I'm thinking more about the future, and I'm so happy that we are having this conversation, because till then, of course, we'll have to find ways to coordinate, but I think so that's where the answer is.
Yes, thank you so much, both of you, for the important feedback. There is another question regarding adjustment of metformin in the presence of SGLT2 inhibitor, and I'm going to take that one because I think that over the time there is a lot of dogma regarding metformin, and I know that I have patients sometimes that come to me and say, well, I've been told that metformin is going to kill my kidney, and this is absolutely not true. So metformin is in fact one of the safest and longest glucose-lowering agent that has ever been. Even if it's in United States has been available only since 1995. In the rest of the world has been used for 50 or 60 years as we speak. So it's definitely a very safe medication. As you know very well now, the FDA also had finally adjusted all these kidney-related threshold. And it's not because metformin may induce chronic kidney disease or may damage the kidneys, just because given the clearance of metformin, when the the GFR is lower, it may interact in some particular condition and may increase the risk of lactic acidosis, but only in very, very specific condition and only when the eGFR is very low. In addition, the SGLT2 inhibitor, as you have seen, and those are just two examples that Tracy elegantly showed with you, even in people with pretty advanced CKD, have been shown to be extremely beneficial, not only in preventing future progression and particularly end-stage renal disease. So definitely here it's an important information, and all of that is also available again on our No Diabetes by Heart. And because we are topping the hour, I would like to thank Tracy Tavera and Dr. Nasir for their very important and valuable feedback. I would like to thank you all. And for those of you that we have not been able to address your question, we at No Diabetes by Heart, we will follow up. Remember to check our websites and remember to check all these resources that are available, including the 2022 standards of care, the patient's educations. And then again, because of our team effort, we are working together across Association American Heart, American Diabetes, to uniformize all this information to be as easily available for all. Thank you so much.